He worked as a surgical resident in Apollo Specialty Cancer Hospital in Chennai from 2013 to 15, and then as a special trainee in surgical oncology at Rajiv Gandhi Government General Hospital and Research Center, Chennai in 2016. He has also learned as an observer in the Department of Supportive and Palliative Care in MD in Anderson Cancer Center, Texas, USA during 2018 last quarter. He has also started a small cancer supportive and palliative care unit in Anna Nagar, Chennai, in the name as Boson Care from October 2020. He has also been a good friend of Pallium India. He has done many courses from Pallium India, and he was also one of the victorious fellows of the Global Fellowship Program pilot batch conducted by Pallium India last year. So, with that note, I hand over to you, Dr. Gajasaraj, to enlighten us on the topic.
Good afternoon, everyone. Hope everyone had a good lunch and are ready. But here to talk on NSAIDs. So, just some. Okay. Second. Sorry. So, am I audible?
Yes, sir, you are.
So you've gone the basic classes of, I think, pain management, and here you're going to see something on NSAIDs. So what is NSAIDs? So first we'll come and find what's the changes that happens in biochemical changes in pain. So the main cause of pain is like any nociceptive pain or pain that is due to any harm to the skin or anything that is harmful externally, which creates um, what do you call a nauseous stimulus, which affects the free nerve endings. So here there are multiple changes, biochemical changes that happen in the body. That is the main cause that happens is like the inflammation, and the inflammatory process is the cause of the pain. And these are mediated by multiple inflammatory mediators called the cytokines, neuropeptides, growth factors, neurotransmitters on the nerve endings. And the main pain causing mediators are the histamine, bradykinins, and prostaglandins. So one of the chemicals that actually stops or reduces the pain is endorphins, which helps actually in reducing pain. So that's one of the things that helps us. So about the biochemical mediators, the excitatory mediators of pain or of inflammation are the bradykinin, prostaglandins, histamine, and the neuroimmune modulators such as cytokines, which includes the interferons, interleukins, and lymphokines, tumor necrosis factors, and the chemokines. While the other one is the neuroexcitatory chemical, that is the substance P, which is also released in the nerve endings, and glutamine, adenine, nitric oxide, etc. So the neuroinhibitory mediators, which include the opioid peptides and cannabinoids and somatostatins and endorphins, like these are some things that actually body tries to protect itself using these inhibitory mediators. So here, these are the channels that pain and heat, cold all go. And as previously, I think you would have seen the pain pathways, which they have already explained in the previous sessions, I think. So here we are going to see the inflammatory markers, the pro-inflammatory markers. There is the chemokines, bradykinins, prostaglandins, and histamine. So these are the main things that the NSAIDs are going to act, and we're going to see how they are going to act. So what are NSAIDs? NSAIDs are the full form is non-steroidal anti-inflammatory drugs, as you all know, and they are widely used and most commonly used to relieve pain reduce inflammation, and even reduce temperature, body temperature or fever. It's one of the most commonest used analgesics in the world, and they work like corticosteroids, but without the side effects of corticosteroids, which work at a higher level than the NSAIDs. Meanwhile, um, they are also used in headaches, pains, and strains. So, and can anybody put in the chat box like what is the commonest NSAID that strikes their mind? Anyone who would? So, so commonest is like acetylsalicylate, aspirin would be the commonest used worldwide, and the other things are like brufen and diclofenac, all those. So the mechanism of action, once the membrane phospholipids are injured, so the membrane phospholipids release like phospholipase, and which actually goes and forms the arachidonic acid, which has two other pathways. That's the cyclooxygenase pathway and the lipoxygenase pathway. So the NSAIDs act in the cyclooxygenase pathway. We'll come to the classification a bit later. So this is the classification of NSAIDs according to its action. So we have this non-selective COX inhibitors, which are the most common ones. So there we have the salicylates, that is the aspirin, and the propionic acid derivatives, which are brufen, naproxen, ketoprofen, and the other one is mefenamic acid. You have piroxicam, tenoxicam, ketorolac, indomethacin, and nabomib. And the other one is pyroxolone derivatives, which are phenylbutazone and oxyphenylbutazone. So these are the non-selective ones. So non-selective are the ones which act on both COX-1 and COX-2 and inhibit the COX-1 and COX-2 as well. So the preferential COX-2 ones are they have little more preference, like they more select more go towards the COX-2 than the COX-1. And do any of you know which is the uh, irreversible one of these? These some of them are reversible. The uh, NSAIDs. The irreversible one is actually aspirin. So um, that is one of the things. And the other one is like you have this preferential ones of the nimesulide, diclofenac, aceclofenac. These are the common ones which are used on the preferential ones. And the selective COX inhibitors. These ones have no effect on the COX-1 and they more go into the COX-2. So the other group is the other group are antipyretics, are the ones that is paracetamol, acetaminophen, which is commonly used in the other spectrum, which also has helps in pain and more towards inflammation than pain. So now I would like to ask anyone who would like to um, say like how is so we'll come to the okay so we'll come to the side effects and go on. So the uses, so as we told before, so they reduce inflammation, pain, fever, and also some stiffness and relaxation of the muscles, so they relax a little bit of muscles. So as you all know, this is the pain ladder of WHO pain ladder, and they come in the step one, so they are the ones which are given for mild pain. So we start with paracetamol and NSAIDs and plus or minus adjuvants, as you know. So we come to the side effects as such. So what are the side effects we see here is the gastrointestinal side effects, which is mainly they cause ulcers, which can be actually potentially dangerous, and they can cause bleeding disorders. And there are another group which can cause stroke and myocardial infarction as well. Also, they are contradicted in kidney disease and liver disease. And we'll come to the side effects one by one. So, does anyone want to ask anything on these side effects. So the next one would be, so as we saw, so the phospholipase is where the corticosteroids act. So they act at a higher level, and they both stop the lipoxygenase and cyclooxygenase pathway in steroids, and while the NSAIDs affect only the cyclooxygenase pathway. So, and we will see why there are some lot of side effects for these NSAIDs. So, as we told previously, the COX-1 and COX-2, they inhibit both, right? So COX-1 has these mediators, that is prostaglandin E2, I2, and thromboxane A2. So all these three have different actions. So these actions help in different things, like the PGI2 has vasodilator and plate inhibition of platelet aggregation as well. While the PGI2 and E2 both actually have a protective lining for they make the protective lining for the gastric mucosa, which we will explain later. Also, the thromboxane A2 is the one that causes platelet aggregation and vasoconstriction in the blood vessels. So these are all important functions in the body to maintain the homeostasis of the body. So the COX-1 is important for the homeostasis of the body, and it's a physiological stimulus they have. So for the inflammatory response, that's the COX-2. But as we saw before, the non-selective ones inhibit both. So the side effects of these are obviously the ones that act on the stomach. Then the other one, I'll come to the kidneys and the platelets. As we see, two of them have platelet inhibitory and the problem of platelet aggregation as well. So these are the issues with the COX-1 of the non-selective ones. So are the COX-2 better than? So because now they have like celecoxib and etoricoxib and all. So the COX-2 should be better than COX-1, right? But they also have some bad effects. So for that, we will see on the further slides. So the next we go to, so the side effects as classified here. So what we were talking previously. So the GI mucosa, the NSAIDs act on GI mucosa. So because of COX-1 inhibition, the PGE2 has as we told, it has the increased mucus secretion. We have increased bicarbonate to reduce the gastric acid, to neutralize the gastric acid, and the mucosal blood flow is also increased by the PGE2, which is being now stopped by NSAIDs. So they cause peptic ulcers and GI bleeding. So this is the main side effect of NSAIDs, which we use as non-selective ones. And the other one is both COX-1 and COX-2 have this PGE2 and I2. So they have an effect on vasodilatation. The afferent arterial vasodilatation happens in the kidney, and these increase the GFR. The other one is they also increase the water excretion and sodium loss in the kidneys. So sorry. So what happens is, here when we inhibit these things, they go into they have hypernatremia, and we have more water retention in the body, and they can cause hypertension. This hemodynamically causes the acute kidney injury in that's why we trying to avoid in already affected patients of kidney, and you suspect any kidney disease, and that's why they don't give it in any person with single kidney or like already operated for single kidney person. So the other one is the cardiovascular. So in cardiovascular, so as we saw, there is platelet aggregation, the platelet aggregation and vasodilatation, one of the things of PGI2 base, and the other one is as well, and thromboxane A2, they have platelet aggregation and vasoconstriction. So when NSAIDs, like non-selective ones, they inhibit both. So they have this issue with platelet aggregation, and so causing some bleeding diathesis. So the other one is like, so we go to COX-2. So here is where COX-2 and COX-1 differentiates. So COX-2, if we inhibit, so there'll be more vasoconstriction, which is promoted by the COX-1 and the thromboxanes. And the COX-2 has a platelet inhibitory reaction, while COX-1 has a platelet aggregate reaction. So the COX-1 overacts and they may cause stroke and myocardial infarction. So they have found out that celecoxib, brictoricoxib may cause stroke or myocardial infarction. So they are mostly avoided in people who had prior history of stroke or myocardial infarction. So this is the main disadvantage of going to COX-2. So this is again the explanation of the COX-1 inhibition by the NSAIDs. So leading to the ulceration in the stomach. So for the renal, as we previously explained, the COX inhibitors, the lipoxygenate pathway causes vasoconstriction, and the COX inhibitor reduces the vasodilatation, increasing the causing hypertension, leading to renal failure, which is acute, which causes the glomerular filtration rate to fall because of the vasoconstriction there. So, so this is the diagrammatic representation of the renal. Reducing the GFR because of the COX inhibition of the NSAIDs. So, which are the commonly used ones? Okay, so the commonly used ones we have here is the for children. So previously, what is the banned drug they used to use? Like right now, it's been banned. So, what was the commonest NSAID which was used in children, which was very effective in children as well, and why was it banned? Can anyone answer?
Nimesulide ban.
Yes, sir. So Nimbus Light. So it so we had mentioned like something called as liver failure in NSAIDs, right? So why it is idiosyncratic because like they couldn't actually find out the exact cause for the liver failure. So suddenly some people went in for liver failure, and the kids had the higher propensity to go for liver failure using Nimbus-Lite. So this was the main reason to stop the Nimbus-Lite. Yeah, and actually still now it's available for adult use. Yeah, and there are some very commonly used ones for the pelvic inflammatory disease and for the uh, pain. They have mefenamic acid, and commonly used ones others are diclofenac and aceclofenac for muscle pain and soft tissue pain. And the in-hospital setting, the commonly used one is ketorolac. So, any scenarios or anything you would like to ask further? Because like so you would like to discuss something on so the drugs and usage. So how often like you all use NSAIDs in the practice? So can I have some answer? So these are the slides I have, and I just wanted to talk on like so if we have a so we can discuss some case scenarios like you would use NSAIDs. So would anyone like to discuss any case that they would prefer an NSAID over any other drug? So what is the next level of drug you give after this? So you go for weak opiates, right? So the next one is tramadol. So most of the post-operative pain and all we try to give like post trauma and all, like the and more inflammatory pains like joint pains are all better um, with the um, our NSAIDs. And so the main things that we need to see that we don't give them or we avoid for people is like for the people with stroke and myocardial infarction, we avoid COX-2 inhibitors. And for bleeding disorders, we try to avoid as such both of them because like, they have action on um, your COX pathway. And I would like to take any questions you have or like you want to ask on anything.
So there's a case suggestion in the chat box.
Okay.
Dr.
Oh,
Sachin
I'm not able to see the chat here. Sorry.
Yeah, so Dr. Sachin has asked if it's a 40-year-old female who's having joint pain, I'm guessing it's a polyarthritis because they've mentioned every joint. What would be the choice of NSAID? That is the question that's come up. A 40-year-old female having joint pain involving multiple joints, what is the choice of NSAIDs that would be used?
So 40-year-old, we will come back to if we'll ask her for any history. So for joint pains, if you go to the side of like preferential COX-2 inhibitors going for like diclofenac, aceclofenac would be the choice, and the availability and the cost is much lesser. And the other one would be going for either ibuprofen. So these have more effect on the musculoskeletal aspect. And the more preferred one was like aceclofenac for the orthopedic group, and ibuprofen as well has good effects. But the only effect in ibuprofen is like it has more of COX-1. So you have to give an what do you so we need to give them a proton pump inhibitor before you suggest any of the NSAIDs that is more on the COX-1, that is ibuprofen. So after a meal and having an antacid before. So these are some things that we need to put. So ibuprofen works well, and aceclofenac would be a good choice. Diclofenac as well, but because of some people having the effects on kidney as well, so more preferentially towards aceclofenac on that part.
Thank you for the reply, sir. And another question has come in from Dr. Sunita. She has asked what would be the analgesic of choice in a case of ulcerative colitis. Analgesic of choice in ulcerative colitis, that is the question.
Analgesic of choice in ulcerative colitis. Okay.
Also, a follow-up question to that also, that is in renal disorders, which NSAID is preferred? That question was from Dr. Madhu.
Patients on renal disorders as well.
Yes.
Okay. So patients on So it depends on how far the generally we tend to avoid with renal disorders, and you would tend to go for other medication than this thing with the um, you would like to go like generally we go for like paracetamol and those kind of stuff with renal disorders, and generally avoid NSAIDs and renal disorders. That's what even our nephrologist doesn't allow us to put anything on as an NSAIDs. But if you Mm, it, I would take a call on that. So,
Are there any further questions?
just um, so is it um,
Nitin, actually, I think sir was not saying anything. That is why he was not audible. Yes, we have a question here from Sonia. We have a couple of questions. Dr. Ajmal, if you will.
Okay.
so generally NSAIDs allergy is quite rare with NSAIDs, and the and for NSAID in case of sciatica, oh, oh, for for sciatica we generally don't like we go ahead with the they don't act that well with the neuropathic pain. So NSAIDs are more towards nociceptive pain, because they more react towards the inflammatory component. And NSAIDs, the allergies are very rare, but if allergies, they have uh, for allergies they have this uh, generally allergies and NSAIDs are like as any other thing, like you have rashes, you have like edema, and it can even cause but they're quite rare. That's what we mentioned.
Sir, if I can add to that, for the
Yeah.
first question, as to referring to the choice of NSAIDs in case of sciatica pain. Sciatica pain is a different kind of pain. That is, it's neuropathic, that is from the nerves, and NSAIDs and our first step analgesics, that is including paracetamol and NSAIDs, tend to have very little effect with pain that originates from the nerves. So if it is pain due to sciatica itself, then the option would be the adjuvants. That is, I think, a topic for another day, but those would include things like antidepressants, anticonvulsants that can be used, which will have some effect for pain due to sciatic nerve compression, which is sciatica. As for your
The one
second
more-
question,
yeah.
yeah.
One more thing was like in renal disorders, generally we avoid the NSAIDs. But if you have to give, I think the one is like the COX-2 inhibitors are preferred over the or over the general or non-selective NSAIDs. But as such, like celecoxib and etoricoxib, they are more
Excuse
preferred.
me, sir. The NSAIDs
Yeah.
will cause more fluid retention. So we can't
Yeah.
prefer NSAIDs in renal diseases because it.
No, but if you have no other choice, then you have to give something. In only
Sir,
an NSAID is there.
Sir,
That's
then
what.
we have to go that the renal damage is at what amount. So we consider it first.
So
If
that's what like. So if there is no renal issue and we suspect something like they are going into something, and so generally that's what we completely avoid NSAIDs. That's what it is. But in chronic pain, patients with inflammatory signs, so for them with a compromised renal function, we can give a celecoxib. That is what has been told. And the thing is like the reduction in the renal function becomes much lesser with selective. It's not that it's completely off. So it's only like if it is about 10% renal reduction in if you give an ibuprofen or diclofenac. So here it's about 5% reduction in the renal function. So for chronic pain, so some like something like rheumatoid arthritis or those patients who have not like maybe like borderline function, they don't have like, if you have a creatinine of 2 or more, then obviously we would not even suggest or look for going all these, like in elderly patients with this thing, like they have a uh, they have these joint pains, but generally with selective ones they are more effective, but we generally tend to avoid them completely. So the only thing we can give would be like a COX-2 inhibitor, that too on a what do you call, like on as use basis. And if there is anything in the renal function, then we should obviously avoid them.
A point to add, in such cases, definitely you can go for step 2 analysis. That's a weak opioid is
Yeah.
also on the table. So
Yeah.
in the case of chronic kidney disease, if NSAIDs are off the table, then definitely you can go for a drug from a highest level. That is, in our case, the available drug would be tramadol. So that is always on the table. And regarding the other question that was on the screen earlier,
Ulcerative colitis.
there was we'll go in order, sir. There was one thing else. Yeah, about the drug to be used for patients who are allergic to NSAIDs. We currently have one patient admitted in our ward who is actually allergic to NSAIDs as well as paracetamol. So it depends on the case. In our setting, this particular patient, she is having hemiparesis, and the pain is mostly felt during exercise. So in those cases, we can go for non-pharmacological management. The pain she reported was rather mild. So in that case, we can go for a topical application of heat, stuff like that. And NSAIDs, you can try rotating it also. They may not be allergic to all of it. And the primary concern would be to find out which of these drugs that they are allergic to. So an allergy test would be indicated in patients who are having analgesic allergy. Find out which of the analgesics, which of the NSAIDs they would be allergic to, and rotate it accordingly. Give another NSAID which she or he is not allergic to, or then again change it up, go to another class of drug that will be used. Again, here weak opioids are again on the table. Okay.
And one thing I would like to add on this, like one, see the other one is like the question on ulcerative colitis. So they are generally avoided in ulcerative colitis. They are not given in ulcerative colitis. NSAIDs, and mainly the COX-1 inhibitors. And because the issue is they aggravate or they cause relapse of ulcerative colitis. So NSAIDs are relatively contraindicated in ulcerative colitis. And the other one would be so regarding the thing, they can cause angioedema, they can cause bronchospasms as well in allergies as such. But as such as I told, like Dr. Ajmal had just told, like there can be allergies, like even for paracetamol, we tend to see some patients like on frequent basis on paracetamol allergies as well.
So, sir, another question has come in. It's from Dr. Sunita, patient of facial palsy, sometimes feeling very severe pain. So, it's an intermittent severe pain, who is a known case of facial palsy. What would be the management? I'm guessing they are asking what would you give for the pain that is suffered by a patient who is a known case of facial palsy. Here, madam, I would ask you to provide a bit more details because as I mentioned earlier, there are types of pain that are involved, and NSAIDs are not useful for all sorts of pain. So, first and foremost, what you would have to do is a pain assessment. Ask them basically where the pain is, how long they've been having the pain, what type of pain it is, whether the pain is localized, whether it's going someplace else from the original site. So you have to do a complete assessment of the pain to find out what sort of pain it is before suggesting a drug for it.
So,
Sir, basically they've asked what sort of medicines that they can give as a first line, basically, for facial pain in this case.
So for facial pain, like if facial palsy with pain, so we're seeing something like a Bell's palsy with pain. So we first need to find out the cause. Like Bell's palsy can be without cause, and it can be without pain as well. The other one is like having herpetic pain. So they can cause palsy with the pain, so which can be dermatome wise, and it is more neuropathic pain. So so generally more more towards like for neuropathic pain management would be better for them rather than NSAIDs as such, because these are more towards inflammatory pain. And any it has been like, so for herpetic pain, it's a little different from the other one. And for herpetic pain, it's a little different. And for facial palsy as such, like steroids help better sometimes for the pain and the recovery as well of the facial palsy if they are sudden and this thing. And if it is herpetic, then we need to treat the herpes with the antivirals like acyclovir and all. So, and then we go forward with the management.
Okay, so the next, I hope that cleared up that question. Basically, if it's pain, definitely first characterize what sort of pain it is, and then you can go for the management. Definitely, NSAIDs come under the step one, so you could try giving NSAIDs, and if it's a nociceptive type of pain that they are complaining of, then definitely an NSAID will be helpful. If not, again, we'll have to add adjuvants to the mix. So the next question is it's a suggestion to discuss about the possible drug interactions when giving NSAIDs.
So as we already saw, like the NSAIDs have So the NSAIDs have this issue with um, um, your gastric mucosa. So any other drug which would endanger the gastric mucosa would be one of them that would we need to avoid. The drug interactions. Um, mm, um,
In this
I
case,
would like to finish the previous one.
okay.
Like the previous question, like the facial palsy with the patient palsy, and if it is herpetic, we go towards like um, the neuropathic pain management. That is like using drugs like um, other like amitriptyline or those kind of drugs, which actually helps for the facial thing. And these drugs don't actually help with facial pain as such. The next thing would be uh, so yeah. So the second thing would be like a bleeding disorder. So as we told, patient taking medication with bleeding disorders, like any patient who's on already warfarin. So these drugs actually have interactions with the with your NSAIDs. So because they also um, have this increased risk of bleeding. So these are generally avoided in NSAIDs. NSAIDs with the blood thinning medication like dicumarol, that is warfarin. And the other one is like usage of uh, ACE inhibitors. So ACE inhibitors, which are used to treat heart problem and BP, blood pressure, and these drugs also are like not used with NSAIDs, as they increase the chance of the renal failure. So patients who are already on ACE inhibitors with um, due to blood pressure and heart problems, so they are also avoided. And the other one would be diuretics as well. So as we saw previously, they are already people are already on like medication for they actually accumulates fluid and uh, sodium. So the diuretics um, are contradictingly acting with them. So they are generally avoided with diuretics as well. So we need to, these are the main drug interactions that NSAIDs um, are we generally look for before starting an NSAID.
Just as a added practical point to the one who asked about the possible drug interactions, there is an actual tool called Drug Interaction Checker. You can search for it on Google. If you ever have a doubt while prescribing an NSAID and they're already on a particular set of drugs, you can always enter these set of drugs into this Drug Interaction Checker, and it'll let you know if there is any sort of interaction that you should be worried about going forwards. Okay. That's just a practical tool for you. Definitely search for it. It is from WebMD, I think, that they provide that service. So you can always rely on it if you want to just be sure about a drug interaction. If I can't find it, I'll paste the link to that in this chat box. Okay. So the next question, sir, is from Dr. Pradeep Kaur, an antenatal patient who is 19 weeks of gestation with severe backache, who gives a history of fall before marriage. What is the management in case of severe pain? In case of severity, I'm guessing they want to know the pain management for an antenatal case.
Okay, so they have specifically mentioned as 19 weeks.
19
One
weeks.
person.
I'm guessing it's
So-
a patient that they've seen.
The question for me.
Yeah.
So it's like specifically at 19 weeks, because like generally about after the 5th month, they tend to avoid giving NSAIDs in pregnancy. Because the issue is like it can cause decreased blood flow to the baby's kidney. So they wanted to avoid the. So generally for sciatica, so the question has been mostly on sciatica and it's neuropathic pain. So more we tend to go towards something like gabapentin and other medication which actually is more towards neuropathic pain. So these are the um, um, and at 19 weeks, um, I, so severity. Um, so and the next question is on trigeminal neuralgia as well. So trigeminal neuralgia is another neuropathic condition as well. So we need to find the cause. There are multiple ways to manage trigeminal neuralgia because like you can have, if, according to severity, we can have interventional therapy for trigeminal neuralgia. And mm,
What sir said is true, because if it is a severe sort of pain, and it's definitely a non-cancer pain, what you described in this situation, so definitely an interventional pain procedure is on the table. And specifically also because she's carrying our the drug study, the use of adjuvants itself in pregnancy, it's not so well known yet. There are very limited data for the use of adjuvants such as antidepressants or anti-epileptics during pregnancy. But the limited data that's available so far, it shows that it's okay, but it's better that we don't proceed with it. So if the pain is severe enough, then a consultation with the pain specialist who can go for interventional pain procedure, that would be the ideal solution. That would be the answer to both the question about the severe sciatica pain during pregnancy as well, who's currently not able to walk, and also regarding there was another question again regarding pregnancy earlier, which I cannot recall, but I
so
guess there also an interventional pain procedure, if the pain is severe enough, can be considered.
so the question like what they had asked on 19 weeks of pregnancy. So definitely NSAIDs are avoided after 20 weeks, that is the 5th month. So the NSAIDs are avoided because they have the severe thing. But with precaution, NSAIDs can be used earlier to 20 weeks. So that is like we can use naproxen or like diclofenac and brufen, but they are only in the first until the 5th month. So because like it affects the baby after that. So other thing would be paracetamol would be the more safer option if you wanted to give something, or drugs for neuropathic pain definitely might help, like gabapentin and all. So more people on pregnancy here. So there's one more pregnancy, first trimester with migraine. So migraine is another another issue. So here
The next question is kindly give severe sciatica pain during pregnancy, patient is unable to walk. So that, as we mentioned before, it would be better to go for an interventional pain procedure if the pain is as severe to cause so much difficulty with the activities of daily life. So definitely, as a baseline, we can go for an NSAID. It's safer up to maximum up to the third trimester of pregnancy. After that, it causes issues with the uterine contractions. It can cause premature labor, stuff like that. So,
Oligo.
so because of that, yeah, up to the second trimester, it's fine. But it's if it is very severe pain, as they have mentioned here, they have described it as being severe enough to cause them difficulty with walking. So in these cases, it is better to have an interventional pain procedure done in the meantime, because higher dose of any medicines is better to be avoided in pregnancy. Also, you could go for the non-pharmacological therapies such as TENS, which is transcutaneous electrical nerve stimulation, which can be of some benefit to these patients.
Yeah, and
The use of opioids, I'm guessing you have another class which is followed up for opioids. So the use of opioids in pregnancy, that will be covered then. So if we get into it, it will be a long while. So just keep this question in mind and repeat it when the opioid class is also ongoing.
so, and the same about the migraine as well. It's the same, like you can use NSAIDs in first trimester, yes. And the paracetamol has been the main choice that's been given for migraine, and they go up to 1 gram. And the other thing is, like, we can give acid in first trimester NSAIDs as well. So after that, I think after the third trimester, that's definitely beyond the 30th week, it's completely contraindicated. That's what it says, because it causes the oligohydramnios. Yeah.
Okay. So the last question that has been posted as it's about a 60-year-old patient who is having trigeminal neuralgia from the few months. Pain is felt when there is, I'm guessing, excessive physical activity. How do you manage the pain? That is a question asked by Raghuveer Ranwa. So again, this is a question regarding neuropathic pain.
Yeah.
60-year-old patient with trigeminal neuralgia.
So trigeminal neuralgia. So this is what we were telling about, like for a few months. So we need to find the severity of the pain and how far it comes, the frequency of breathing, and if we are able to give him something that can, like, interventional pain will be helpful for him for reducing the pain. That would be first choice if the person is for quite a long time and all. And as such, as I told, it's more towards neuropathic pain, and we need to give him uh, uh, pain medication, which actually NSAIDs um, may not be that helpful.
Again, as was the point with all sorts of scenarios that you have suggested, the most important factor is first you have to assess what sort of pain it is. Because as we've been repeating time and again, it's different drugs act for different kinds of pain. And NSAIDs are mostly reserved for nociceptive pain. That is basically what you described as trigeminal pain. Trigeminal neuralgia is definitely nerve pain. So NSAIDs have a limited role in controlling pain from the nerves. So again, there the option would be to go for an adjuvant drug, which
Correct.
we have not covered in this
So
session. So
anticonvulsants like gabapentins,
antidepressants, stuff like that can be used. So those would be the drug of choice for pain due to trigeminal neuralgia, which is purely neuropathic. Also, I'd just like to draw everyone's attention to the chat box. The drug interactions that are the link to it has been posted. So if anybody ever has any doubt regarding use of any drug while the patient is already on a few other medicines, you can always check it in this link provided.
And these both the NSAIDs and the corticosteroids have much less effect on trigeminal neuralgia as such. And they are more effective with anticonvulsants and other neuropathic medication. And depending on severity, we can increase the dose of those drugs. Not and NSAIDs will not be very helpful for them.
To answer your question, if for a lack of a better option at this point of time, because the adjuvant clause has not yet been taken, if the question is pain management, you can definitely go for a step higher, go for tramadol if you want to manage the pain, because tramadol has a bit of action on neuropathic pain as well. So if the neuropathic pain is your concern, then definitely you can consider tramadol.
Neuropathic pain, tramadol also can be considered.
Dr. Ritika, we see your hand raised. You're muted. Dr. Ritika, if you're trying to communicate, you're muted.
Other pain management options. Okay, can you be more specific on that, sir?
So I'm guessing we have asked for other than the use of drugs. So I'm guessing what you mean is non-pharmacological. If that is what you mean, can you confirm whether that is what you're asking about?
Yes, sir. Non-pharmacological.
Non-pharmacological, definitely. So first and foremost, as to where the pain is, time old tradition is if something hurts, you rub it. Okay, that is physical stimuli. That acts as a gating mechanism of pain, the physiology of which we will not get into now, but definitely axial massaging helps. Okay, for certain types of pain, local application of heat that provides relief. Then there are methods that are used by physiotherapists that was briefly mentioned before, that is TENS, that is transcutaneous electrical nerve stimulation. That can also be used to help with certain types of pain. I'm not saying that all sorts of non-pharmacological therapy can be used for all sorts of pain, but there are definite use case scenarios. Again, some of the scenarios that were mentioned here were neuropathic, and for those sorts of pain, non-pharmacological management tends to be not very effective. Okay, for those that we will require some amount of drug therapy. For the normal non-susceptible pain, pain due to injury, stuff like that, definitely you can go for gating mechanism, you can go for local heat application, you can go for TENS, things like that.
No, that is what, like heat application and because they go through the lateral pathways and the so what they call they block the gateway, like so. So that is how I think like the other managements can work. The other thing are intervention, as we told. So local blocks, something. So they tend to like knock the thing off, like the what do you call the free nerve endings and the channels. They can be blocked. So those are the things that we can use for this thing. And non-pharmacologically,
also definitely there is
reducing the stimulus.
Yeah. Also, definitely there is a question of correcting the correctable things that you can do. And that is where the assessment of the pain comes in. You have to always ask what is causing the pain. In some cases, if it's a bedridden patient, they may be having pain just because there's a diaper rash that has increased. Okay, so the cause, the root of the pain, that has to be definitely assessed. You take a proper history, you take a definitive assessment of the pain. And if it's a localized pain, you go take a look at that site where they're complaining of pain and look for things that can be actually corrected. Okay. Um, Maybe the pain is being caused due to local pressure due to something. So just remove it. Stuff like that is the first step that you do. Correct whatever you can correct without the use of drugs. Second step is basically massaging that area may help. Local application of heat may help. Then obviously the actual things that require some expertise, that was what I mentioned about TENS, that can be used as well.
Yeah.
After that,
So
specific therapy depending on what the actual pathology is. That is again going into the territory of using drugs.
So first to find the for the nociceptive pain, what is the cause of the pain? What is actually causing it? Is there something rubbing over it or something like that? So that has to be first removed. So those are some things that we can ideally do for them, like for as far as diaper rash, like emollients and things to like not have something like rubbing on them. So as Sarah told, so those things are important as non-pharmacological, and um, uh, it is something like what they used to say, like one joke they used to say was like uh, a person used to say like he has pain all over the body, but actually whenever you touch you have pain. Actually the pain is in the uh, sorry, the finger. So the finger he touches, he says, and so it's something like that. So first of all, we find the cause of the pain, and then we treat the cause. So that would actually solve a lot of issues.
Are
So
there any more
nerve
questions?
So anti-inflammatory effects are more in NSAIDs, and for I think neuropathic pain and this thing you would have a different topic by itself. And yes, sir.
Was that a question? No. So are there any more questions?
एक्सक्यूज मी सर, वन मोर क्वेश्चन हियर.
Yeah, go ahead.
सर, जो ओपियोइड्स आते हैं इसमें ओरल ओपियोइड्स में जो ओरल होते हैं और इंजेक्टेबल होते हैं, इसमें ट्रांसडर्मल पैच भी होते हैं सर. इसमें तो फिर बेटर कौन सा ऑप्शन होता है पेशेंट्स के लिए, कि हम ओरल दें या फिर आईवी दें या फिर ट्रांसडर्मल पैच लगाएं?
Okay, so the question was as to which would be the most effective way to basically use opioids.
Yes.
That is what I understood.
Right.
Effective way to use opioids, sir? Effective way is what
Effectively,
like
okay, fine. So the thing would be one, you have an opioid class pending, so I won't go into too much detail, but what you have to know is all three forms are equally effective depending on how they are used. Okay. Most often parenteral, that is IV preparations or injectable preparations of opioids, are used when when we have the requirement for acute management of pain. Suppose a patient comes to you and they say that the pain is very severe. It is the most amount of pain that they've felt ever in their life, and they come to you with such a situation. Then what they need is immediate relief then and there. In that particular situation, the most effective form of using opioid would be injectables. You can give it IV, you can give it subcutaneously. But in that situation, the most effective form would be an injectable. But then you have another patient who is more or less comfortable. Okay, they have been on oral opioids and they have adequate relief with oral opioids, and they've come to you again. Sir, I'm taking this drug and it's okay for me. Okay, that is what they say. Okay, then in that case, there's no use in shifting them over to another form of drug. And the local patch that you mentioned, that is reserved for patients who have been on some other form of opioid for a while and they have become comfortable on that oral form. and that particular dose of drug has been enough for them. And if that plateau phase of pain has been achieved, then definitely as a, let's say, an improvement in quality of life so that they don't have to take so many oral drugs, in that case, you can go for patches. So 3 forms of drugs that are available, you can definitely use it. All 3 have the same efficacy, but their effectiveness depends on the patient situation rather
Okay.
than a common action for all forms of pain. That is where the history comes in, that is where the assessment comes in always. So that is always what you do first. You take the history, you assess the pain. Sir, would you like to add something to that, or?
For opioids. So first, that's
Thank
what,
you.
as we say, like opioids, the first thing would be, first we see the scale, like as I told, like first we need to find the pain scale. What is the level of pain he has, and what is the acute severity he has. So if he is already on some opioid or not. So for an opioid naive patient, or already he is on some kind of an opioid, like at least tramadol, which is a weak opioid, then we would go on and we first find the type of pain. So if it is more of say neuropathic, or like something like even very severe nociceptive pain, so they are very effective for severe nociceptic as well. So we could have initially that we go according to step ladder of WHO. So as mild, moderate, and severe, right? So how do we classify? Mild is like less than 5, you have mild. So 5 to 7, moderate. 7 to 10, it is severe, right? So we classify according to that, and then we give them on opioids. And it depends on how severe it's been. Like he's in acute pain crisis, and he's like uh, trembling in pain, and like showing so much in casualty. He's like moving around. He's like trembling in pain. Then you can give some even an opioid trial uh, for him. So these are some things that over the period of time I think we should see, because like suddenly a patient coming with so much pain. So we need to first find the cause, and then the severity, and then go on with this thing. So you're trying to change from an NSAID to opioid. Yes. So we find the severity. We go to weak opioid and then through strong opioid. For cancer pain, it's a little different. So we go directly to that is step 3. So we can go from we can skip the step 1 and step 2 and go for step 3 as well. So meanwhile, we need to look for the side effects of opioid as well. Am I okay, sir? Was Dr. Ajmal, sir?
Yeah. So, as for your further doubts regarding actual use of opioids, you will be having another session on the use of opioids. So, they will be telling you about how to initiate these opioids and when to consider different forms of opioid. The overarching tenet will always remain that you look at the patient and you deal accordingly. Okay. All 3 forms of opioids will be providing them with relief, but the question is when and how. So that is what you look at. Further details will be provided during the next session. Okay.
The one more thing, just like I think some person asking post herpetic pain already. I think they've been asking. So here someone has replied as gabapentin and gabapentin. Yes, we can give these 2, and the drug of choices would be I think amitriptyline and duloxetine. These are the ones that are the drug of choice initially to be given for post-herpetic neuralgia. I think the dosages are such like we can look it up and read it.
Again, the question is post-herpetic neuralgia. It's in the name. Neuralgia is again neuropathic pain. So neuropathic pains don't tend to have much effect with NSAIDs, which is our topic. And the responses that were given were either pregabalin or gabapentin, both of which are class of drug that comes under adjuvant drugs. Okay, and
Adjuvant
yes, it is true.
and
You can actually go
antiepileptic.
for gabapentin or you can go for pregabalin, but do keep in mind that pregabalin as a drug, it is quite expensive, and gabapentin, its dose to response curve that tends to be variable for each patient. So definitely, you can go for any of these drugs as a first line management. In case of gabapentin, it will be 100 milligram at night, a starting dose. You can also consider other forms of drugs. You can go for antidepressants. There is amitriptyline and as I mentioned, duloxetine. If you're going for amitriptyline, you can always go for a starting dose of a half tablet, depending on what's available. In our place, the tablet strength tends to be 25 milligram. So we go for 12.5 milligram at night as a beginning dose. But if you're not yet trained with the use of adjuvants, I would recommend that you send them to a pain specialist for the time being. Because it is better to start a particular drug only after you're aware of its possible side effects, aware of its pharmacokinetics as such. So the possible option here is amitriptyline or duloxetine, which come under the same class, or pregabalin or gabapentin or valproate, which comes under another class. But again, the dosing, the hiking that may be required in the future, all of those are a future topic. So in this case, definitely, if it's severe pain, you can try giving them tramadol. Because again, as I mentioned previously, they do tend to have some effect on neuropathic pain as well. And the adjuvants, you really need to be aware of its dosing before you start prescribing it. But yeah, as the answers that are given, they are all valid. They can be given for this pain. Are there any more questions?
So most of the questions are more towards neuropathic pain. Most of them.
Yes, definitely. Most of the questions had something to do with neuropathy. I don't know if there is a session that has been scheduled on the use of adjuvants as such, but like we did now, even during the opioid session, I'm guessing you would be touching up on the adjuvants. So you will be provided with at least some clarity regarding the use of adjuvants for neuropathic pain. Just know that adjuvants are of use for type of pain which is of origin from the nerves, that is neuropathy. And there are a few class of drugs that can be used, including antidepressants, including anticonvulsants also. So those will be explained hopefully in a later video. Are there any further doubts? Please share PowerPoint of today's and last two sessions.
Actually, last two sessions, all the materials have been uploaded. You will be able to access it only if your account is active. So that is why we have been repeatedly requesting everyone to kindly complete the IECO registration or get in touch with the support of IECO India team directly. Because most of the cases which we were able to address, we had already addressed. And if still you are facing difficulty in accessing your IECO account, there is a support option in their page, ieco.org. Please do get in touch with them, or you can email to us so that we can take it up further with them. Already we have shared both the sessions, PPTs, recordings, and all materials. And today's session with the PPT will also be shared in 1 day or 2.
I will send it.
So it is on the IECO
And-
platform to those of you who want the PowerPoint presentation as well as a session recording.
No.
Okay, if there are no further questions, sir.
Thank you so much.
Sir.
Actually, I would like to thank both of you, like Sri Priya and Ajmal, Dr. Ajmal. So, and thank every one of you for listening, because like this is my first ever Zoom class. I've never taken a Zoom class before. So you're all my guinea pigs actually. So, and thank you. And it was a different experience because like it's very different from a normal class. So, thank you so much. It was a different experience. I learned a lot. Yeah.
Thank you, sir. The PowerPoint presentation was very detailed. You went into quite a lot of detail about the pharmacological aspects of it, of the possible mechanism of actions and all. It was very well done. And I'm pretty sure you managed to clear a lot of the doubts that were asked. even though some of them were outside the scope of our discussion today, it's, I think, it was a learning experience for everyone involved today.
Yeah.
Thank you, Steve.
It was very different. Yeah. Thank you so much.
Thank
Thank
you,
you, everyone.
Dr. Gajasaraj, for joining us. Thank you all the participants for making the session interactive. And with the promise that we will meet again in the next session with another topic and another eminent faculty. This is Sri Priya, along with Dr. Gajasaraj and Dr. Ajmal signing off from the Tips Hub. Stay connected,
you.
everyone. Keep spreading happiness. Bye-bye.
Thank you.